Nathan, I see you have somebody else with you.
Yes, Frances Earnhardt is joining me. She's one of our integrated behavioral health specialists.
Hi.
Great, welcome, welcome, Francis.
Thank you.
People are coming on in. Let's give everybody a second here. There we go. Folks are coming on in. Let's just give them a second. If you guys are eating lunch, that's okay with me. Sometimes it's the only chance we get, right? I'm drinking my afternoon tea, so. Well, welcome everybody. Today is our follow-up office hours. Traditionally, it follows last week's training on behavioral brief therapeutic interventions, which can be used in the primary care setting. But I'm pretty open to whatever questions you guys have. If I know the answers, I do, and if I don't, I don't. And if it's coming up in a webinar down the road, also, I'll let you know about that, so that we can, have more time on that later if needed. So last week we talked about, we did a quick tour through those interventions proven to work in the primary care setting. We talked about motivational interviewing, which all of you guys know, been promoted in primary care forever, but specifically about using motivational interviewing to talk people into, if they're reluctant, into getting behavioral health treatment. We talked about probably the most used therapy, brief therapy for depression, behavioral activation, and how really straightforward and simple it is to do it. We all think we've been doing it, but the hook was making sure we follow up with people on their goal at the time they specified. We talked about problem-solving therapy, specifically 7 steps, top to bottom, 7 steps. Give them a worksheet, manualized, ready to go. All kinds of people in your organization can do problem-solving therapy. Talked about half smile. I'm sure some of you practiced half smile this past week, your Mona Lisa smile, and taught it to a patient. We talked about adapting a couple of the 21 dialectical behavioral therapy skills and how you can very easily buy that spiral bound notebook, has all the sheets, all the worksheets in it for the patient, and use it with your patient. And I think, and then we launched into something new. We launched into written exposure therapy, which is way cool. The thing I know the least about, but have tried to learn the most about, which is a brief 30-minute intervention, 5 sessions, again, used in primary care to treat trauma, all kinds of trauma, ongoing trauma from the past, or specific trauma like got in a wreck last week and I'm having a hard time. So we talked about a lot in a very short period of time. So the goal of today is to follow back up on that and start there. And I'm really curious, one, does anyone have any questions about what we did? But most importantly, number 2, who tried something a little different last week? Doesn't have to be perfect, but who tried a little something last week based on what they learned? I know one person was saying, I forgot her name, that she was going to try written exposure therapy, that she was kind of intrigued by that. And maybe some of the rest of you did other things. So let me be quiet for a second and let you guys either in the chat box or just unmute yourself. Tell me something that you might have tried, even just a little bit, even if you didn't do it full force. What's something you tried last week based on what you heard? I hope somebody tried something.
Well, Lord, we've been trying, it's sort of similar to the written exposure therapy. It's called prolonged exposure in a PCP setting. I don't know if you've heard that. It's quite similar to what you're talking about.
Does it have the writing exercise?
It does.
Okay. Could be similar. It's been given a couple different names, but written exposure therapy is the one that I've heard. And how do you do that? What does that look like, Nathan?
So we
Is
go
it
over,
how many
we go over
sessions?
yeah, we go, it's usually like 4 to 8 sessions. And we go over it and give them like the packet and stuff, and they write the trauma. They don't write it in session, they write it outside of the session for 30 minutes and then read over it a couple of times before they return the following week. And then we go over that with the processing questions in session and basically repeat that process and do the PCL score each week.
Okay, very similar, but with written exposure therapy, it's more you're there with them, no homework in between, except let your feelings and emotions happen. Don't try to suppress them or anything. Think about them. But yes, some similarities, but it is different, definitely, because we're trying not so much to do prolonged exposure therapy as we are doing a more of a distancing exercise in repeat. Do they repeat the same one over and over and over again? Good. Okay. So these two have some common characteristics that I think one of the big differences is doing it with the therapist in their office versus making it a homework assignment. And hopefully with a homework assignment, they do it, but they may not. And then reflecting on it before they leave your office and following up on it briefly, not on the details, but on the feelings and emotions. So it's a little more focused on the feelings and emotions rather than maybe, like you're doing, Nathan, processing a specific trauma. So that's interesting, that exposure therapy. If you have a link for that, Nathan, and want to throw it in the chat box, that would be great. I don't know if that's from the VA or somewhere else, but thanks for sharing that you guys have started something. Are you noticing PCL5 scores falling?
Yes, I've had great success with the intervention. Of course, there's a couple of people who, don't want to do the homework or don't complete the homework. And then there's a couple of people I had spoke to about the intervention, and now they've missed their next 2 sessions. So I'm gonna have to, contact them and say, hey, we don't have to do that.
Yeah, maybe you can say, hey, I've got a new way of doing it. Let's just sit
Yeah.
here in the office, because it may be too painful for them to do it, or there's too much chaos with all the kids running around. Who knows? And now they're avoiding you because they know they want, you got to show your homework, and they don't have it. So now they're avoiding coming to appointments. Yeah. And I think written exposure therapy, when the VA did it, they were trying to overcome some of those barriers. Patient doesn't do it, so now they're, not ashamed, but they don't want to come and tell you they didn't do it because they're scared you're going to fuss at them. I think that's part of the goal of what maybe the VA was trying to overcome, was some of those things. So the goal was really to make sure there was no homework outside of the appointment. So that's interesting to hear, Nathan, and maybe something will happen where maybe you'll throw in a little slice of just do it here in the office instead of having them take it home for homework. I don't know. Maybe that would be something worth giving it a shot. And that writing assignment should be, 15 to 20 minutes of the 30-minute time. 5 minutes is check in. What kind of emotions did you experience this past week? And then the last part, and then right after that, you give the instructions for this week. And if anyone wants the specific instructions, I have literally you read a script. So it makes it even easier for you. I have that, and then they write, and then you say, how was that for you? Not the specifics. You just want to know, how was that for you? So, okay. Thank you, Nathan. And then, who else? Someone was going to try it. Tiffany, I'm not sure if it was you or someone else was going to try to maybe give it a shot.
Yeah,
Yeah.
it was. I was I did present it to my patient. I was just gonna get her used to the idea of, hey, let's plan to start this at your next visit. And she was like, so are we gonna do this? I was like, oh, okay, so we're doing this now, because I was gonna wait for the script and a little more understanding of it. So we did move forward, and I was a little surprised and pleased that she was so ready to get started on it, because I've been seeing this patient for quite some time, and she's been very resistant to talk therapy, talking through her trauma. So she really took to the idea, and then afterwards, I had some questions that came up, such as, do I read what she has written? Because then she did hand it to me with the expectation that I read it, not aloud, just to myself. And I didn't have her go through detail in discussing, but I was like, what was this exercise like for you? Or, what type of emotional responses or what type of thoughts did you notice was coming up? And at the end of it, did encourage her to just allow herself to sit with her emotions this coming week, as opposed to like constantly doing things to avoid. And she was open to and receptive to giving that a try this week.
That's great. And you don't want to spend too much time on the details. What
Right.
you want to do is review her writing to see if someone is writing the details and not writing the emotion. That's what you want to do, rather than go through the details. And let me just show you the so just so that you guys know, like session 1, you literally read this script. So Tiffany, you would just have this kind of sitting there and you're looking at it, and you literally read it. Over the next 5 sessions, I want you to write. Don't worry about your spelling. Write about the details, how it happened, who was involved, write about the specifics, but most importantly, what were you thinking and feeling? And so when you review what they write, Tiffany, this is what they sometimes leave out. So that's what you're reviewing their writing for. Okay. What did they potentially leave out? And then you tell them, try to be as specific as you can, explore your very deepest emotions. Okay. Keep in mind, you have 5 sessions. You're going to write about the same one over and over again. You don't need to be concerned with completing everything today. Just be sure that you write as much detail as you can remember, and your thoughts and feelings as you remember them. Okay. As you remember them during and immediately after your trauma. What were you experiencing back then? Remember, it's a distance approach. If you think about back then when this happened. Okay. So, and then for the first session, I'd like you to start at the very beginning, the moment you realized it was about to happen, describe it, blah, blah. Okay. In addition, so again, this is scripted. All right. Very scripted. And this is what you do at the end, Tiffany. When you're at the end of the session instructions, you're talking about what may come up between now and next week when I see you again. All right. Let them happen. Allow them to happen. Don't try to suppress them. Don't try to push them away. Have whatever thoughts and images come up. All right. And then on session 2 to 4, you do the same thing. I want you to continue writing. I have blah, 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 blah. Okay. That's session 3, session 4, session 5 is your last one. And you want to ask, and again, you're doing your PCL5s and stuff. Was it beneficial? We have tools to help you. And are there areas where you need some more work? And then if they continue to have sessions, you can do more sessions if you want. Do it with a different trauma, not the same one, not the car wreck. Use another evidence-based practice like Nathan was just talking about. Or you may want to send them for EMDR or something else. Okay. So what's so cool about this, and this is from Uniformed Services, they were teaching people how to do this, is it's incredibly scripted. So it's kind of nice for you. You don't have to wonder, what am I supposed to do and am I doing it right? They actually give you the script from the evidence base, and they went head to head with prolonged exposure therapy. And if I remember, it was either non-inferior or better. It might have been better because people didn't have homework. It was at the top, one of those slides at the top. But if you're non-inferior, that's incredible. That means it's not worse than. That means it's either equal to or better than, what happened with traditional exposure therapy, which is, what people think, oh God, here we go. We're going to get in a group and relive our trauma and, whatever else. So, okay. And Tiffany, I can send you, I don't know if I have a link to those slides, but if folks are interested, I just closed it, of course. I can send you that so that you have the script.
I would love that. Thank you.
See if this sends you where you want to go in the chat box, if I can find the chat box. Give it a click on the link and just see. I'm not sure exactly what I saved. These are the instructions and the handouts. No, it might not give you what you want. It's not, I don't think it is. Anyway, I can get it to Stephanie and we can get that sent out. If you click on it, you can't get it. Okay. Cool. Okay. Anybody else try even little elements of written exposure therapy? You don't have to do the whole thing. But anyone else try some elements of it? Or what did you think about it? Because one of the things you guys said in the survey that Stephanie sent out is you are having a whole lot of trauma coming into your centers. What do we do about all this? It's just overwhelming us. And it's true out here in Western North Carolina. I don't think I have a patient coming into a community health center that doesn't have trauma. It is overwhelming. Or to hear what the rest of you are doing about trauma, because many of you put that on your questionnaire. What's the approach your site's taking? You guys are incredibly quiet today. It's a beautiful day out there. Let's see what's cooking here with everybody.
I'm sorry, Lori, were you asking for different evidence-based practices people use for trauma?
Yeah, you had told us about the one that you're using. And so if anyone else have anything else they used or any other thoughts about written exposure therapy, do you think it's doable in your setting? Because a lot of people were worried about trauma. That's one of the things you mentioned and wanting more about in this session. And I want to make sure we've met people's needs around that. I think there's a lot of therapists on this call. Or other techniques that you use. Anybody? You guys are really quiet. It's okay if you're all eating lunch, but you'd unmute and give us some examples of maybe what you've done around trauma or just anything you thought about how you're doing therapy in a community health center.
Lori, we have several therapists here that do EMDR, and I've tiptoed into the realm of ACT therapy too sometimes. ACT therapy, I find it helpful for some people.
A number of people I've heard integrate ACT into elements of ACT into brief interventions in primary care. I think EMDR is a tricky one. Do you have the luxury to do it? Makes it tricky, but I did hear of someone using the luxury of time to do it. Maybe your center does, but I've also heard of people integrating some elements like some tapping elements or something from EMDR into sessions, even if they're not doing full on EMDR. So that's a good point. Raney, did you have something you were about to say? Raney, I can't hear you. I know you're, oops. I know she came off mute, but I didn't hear. Okay, Raina, do you want to just put what you have in chat box? How about other folks? What do you have that you tried last week, intrigued you about our talk last week? We're only 21 minutes in, so we have plenty of time. Don't be bashful. Or just put it in the chat box if you want.
Lori, I do have a question, actually. So in the wet exercise, sorry, my camera has messed. Oh, there it is. So do they write present tense or past tense
On which one?
on the written exposure therapy?
You take a distance approach.
Uh-huh.
So, let me just pull up. And this will answer Raina's question too. Let me just pull up my slideshow from last week. Let me find it. Hey guys, gotta hang in here with me. I'm gonna show it, I hope. Share screen. Okay, you guys see that? Everybody see it? You see it, Nate?
Yes, I do. My camera's acting funny. I'm sorry.
That's okay, just want to make sure. So your question was, are you talking about past tense, right?
Yeah, if they write in past tense or try to write in present tense words.
Oh, you want to take a distance perspective. That gives them a little separation, psychologically, and this is what happened. This is what happened then. The thoughts, the feelings, the emotions, and the description. Okay. So that distance perspective actually helps reduce anxiety, as they're trying to write it. Gives them a little distance from the trauma, from the emotions, and makes it a little more acceptable or doable, right? We don't want a type of treatment that is so disturbing. Now, the nice thing is you are in the office with them. When they have homework in between, you're not so much there if it gets disturbing for them. So a distance perspective, and that's in the script. Nathan, in the script, it says thinking about what happened. So here's, as you look back on the event, okay, those are kind of the words in the script. We want to know the details of emotions felt at the time, not so much the process, except to make sure, as we were talking earlier, they don't leave the emotions out. All right. And they need to select a memory, and remember, they're going to write about that same thing over and over again, 5 sessions. The fact that they write longhand, no typing, that really slows down that thought process and lets them put in as much detail and emotion and thought as needed. Okay. And then there was a question in the chat box about, about why are we doing this? Why this versus something else? And what happened with written exposure therapy is in the VA in particular, they were looking for something they could do in primary care. Otherwise, all these guys and gals from who had traumatic experiences had to come in for hour-long therapy sessions or group prolonged exposure therapy. And the VA said, there's got to be something else we can do. And so they developed, the theories behind this have been out there for years, but they developed this model based on some learning theory over time, and they tested it head to head with prolonged exposure therapy. So traditional prolonged exposure therapy, you got to send someone somewhere else, typically outside of primary care, to do it. So the goal of this is to allow you some tools in the primary care setting to do this. So the lessons that are being learned over those sessions is the memory isn't dangerous. It can be experienced. Distress is, if it's there, is transient. The distress reduces over time. So as you write and write and write and write, all you're doing is writing, and that distress continues to reduce. Things like your heart racing and sweating, they're not going to kill you. Remember, that's what we tell our patients with panic attacks. It's not going to kill you. That negative affect can be tolerated, and it's really nice. The therapist is sitting right there with you. And what it does is it allows you new ways of thinking about trauma and its meaning. Just that writing 5 times over and over and over. You know, you can see how that would begin by the end, you're going, I'm getting a little bored with this. You know, writing over and over about it just begins to separate you from the thoughts and emotions and go, okay, I get it. I can deal with this. This isn't going to hurt me. I've reduced my distress around it. Does that help? I'm just running back to the chat box real quick. Someone I supervised last week had questions. What is the goal? So we talked about that following the 5 sessions. And should we also consider using other interventions? So also for the clinician, during the time the patient is writing, should the clinician be doing anything else during this time? Someone had asked that last week also. And I think if you are sitting there quietly reading patient notes or, you know, doing some things, you just don't want to be, you know, tappy and loud or talk or, you know, doing emails. Or is there something you could be doing? Reviewing maybe their last writing session. I think it's just about being quiet and thoughtful because they know you're there. So I would think about that. Yes, you can do some other things. You don't have to sit there and stare at the patient. That's probably going to make them feel a little uncomfortable anyway. But think about other things you could do that were quiet, because if you're smacking on those keys of your computer, it's probably going to be distracting to the patient. If you can sit a little further away, like you're at your desk and maybe they're over in a chair, if you've got that kind of space in your office, that could be helpful too. Make sure you either have one of those folding tables, you know, that fold over in front of a chair, or a clipboard or a table. Make sure the patient has somewhere comfortable to be doing this. So doing it in longhand, so they're not tapping away on their phone or a computer or anything. So if you get a little distance, you might be able to quietly do a few other things. So think about that. So these are the goals right here. Those are the goals. And then the process is just, you know, just be careful about what you're doing. Okay. Does that help? Does that answer your questions, Raina? Anybody else have questions around this? Thank you, Raina. Okay. Because this is what we're trying to do. And again, I don't have all the research, but you know, this is I have the whole other document. There's a really nice document from, because remember the first session, you're going to actually do some psychoeducation. Okay. There's a really nice handout from, I think it's the VA, on this type of treatment that you can hand to patients. Here it is. This is what we're going to do. And then have them come back maybe next time to get started. Although one of you, Tiffany, your patient's like, let's go. I'm ready. Let's do it. So that is just, one of the things to think about. And I think another thing that was mentioned was making sure you're tracking. So to the point, how do I know if this is working or not? Making sure every week or two, in the study, they did the PCL5 every week. When you pull the PCL5 offline, and I think it's actually in the VA, they have the best bunch of resources for trauma, including any mass trauma, things like that. But they have a PCL5 that's set for a week. In the past week, have you had any repeated disturbing and unwanted memories in the past week? And then they think they have one in the past 2 weeks. And then they have one that says in the past month. And then they have one that says the initial. So take a look if you want to at what the top, see how this one says in the past month. So this is my monthly one. They have a week and I think they have 2 weeks. So if you want to do this every visit, and I'm not sure, Nathan or Ted, if your group is doing this every visit, but if you want to, you can actually get this right here because they might get confused if you're asking them in the past month and actually in the past week, they've been feeling a lot better because of what you're doing with the written exposure therapy. So make sure you pull down the right one. That's the only thing I would say about that. Any questions about this? About how to use it or I think it's just really cool. Haven't used it personally, but and then I think it's, you guys have tried some other things. I think grounding techniques, adapted DBT skills. There's all kinds of other things you guys do with patients who have trauma. And maybe those are some of the things you do before you start written exposure therapy, right? They're having a hard time. They need to do a little grounding. While they're sitting there in the office with you, they need to sit back and do some deep breathing because they're talking about something hard. That's okay too. You can teach them the other techniques that prior to getting started on written exposure therapy. It's like EMDR, right? You got to get people ready for EMDR. You just plunge into it, and you might have a emergency going on in your office right there. So teaching them a few skills before they get started is fine. Don't make it part of your 5 sessions. Make that, we're going to do this. I want to teach you a couple things. Let's get started next time, that kind of thing. Okay, other things, behavioral activation, problem solving therapy. Anybody try any DBT skills? Anybody order the manual because it's like, hey, I get some things I can tear off and use. You can put it in the chat box if you want, especially if you're eating. Tiffany and Ted and Steffi and I are going to get tired of looking at ourselves. Everybody else got their video off. I know other folks must have burning questions or some experience. Who wants to go next? Angela, there you are. You want to go next? Hey, I love Lay's potato chips. But I can't hear you.
Oh, sorry. Okay, I'm clicking here. You can tell I'm multitasking. So this is actually,
I was eating potato chips earlier, so
yeah. So this is actually the first time that I've been in here. So I was kind of listening and picking up on everything. I am currently doing the EMDR and going through all my consultations and things like that. So I get where you're coming from on preparing people for the whole EMDR. So I'm really just here I don't know that I have a lot to add at this moment, but
well, Angela, how do you prepare them? So what is it that you do before you start? Because I think it's important for some of the other things we've talked about too, is preparing patients for what we're about to do.
yeah, for me, I want to make sure that they're well informed and they're educated and they know everything that's kind of going on with what the process is going to be. And then obviously I want to make sure that they've got the grounding skills and they know how to kind of self-regulate and kind of guide through um, just the dynamics of the tapping and everything else. So just what, having that safe space to go, what happens when things come up that we're not really going to like address in that moment because we're going through the process, how to put that in the container, things of that nature. So for me, it really is because I work a lot with kids too. For me, it is really making sure they know how to kind of self-regulate and preparing them for when things do come up. In school systems, it can be difficult, especially when you're dealing with past trauma and things, because you really don't want to pull that out in second period and send them back to class for the rest of the day. So just a lot of consideration in that. And yeah, I mean, each patient's different.
I think whenever you're working with trauma, that preparing people and teaching them some skills is a super, I mean, it's just an important part of the treatment. Someone was asking earlier, what else can you do for treatment? And some of it just sounds so basic: deep breathing, grounding skills, any emotional regulation needed around it, distraction, which is one of those adapted DBT skills we talked about last week. There's so much you can do for people with trauma. And then when you want to go into the meat of it, we've heard today about a brief prolonged exposure therapy treatment. We've heard about EMDR in primary care. We've heard about written exposure therapy. So, 3 things kind of right off the bat, because again, Western North Carolina, I haven't found a patient that came in that didn't have trauma. So we all need those tools to deal with trauma in primary care and to do it briefly. I mean, if someone needs more than that, where do we refer them? And sometimes we don't have anywhere to refer them. So you do the best you can. If you get, I don't know, if the PCL5 gets down at, 35 is the cutoff for positive PCL5. If you can just, get it down to 40, get it down to somewhere. It's not going to be perfect. That's never going to be perfect. Don't promise patients 100% you're going to cure them. But using those tools that you already know and some new ones that you've learned about here, I think are super important. And just using elements of things, DBT is probably one of the top treatments for, the sequela of trauma. And we can't run DBT groups or don't have them in our sites. So we end up not having one of the biggest emotional regulation tools we could use out there. It's what we use primarily for trauma here at Mayheck, is to get people into DBT group so they can regulate their emotions, stay in wise mind, do those things that they need to do. So adapting what you can is important. The next question I want to ask is, as people heard this, it's like, wow, okay, in primary care, there's this new expectation, and it's happening across the country. No one's picking on North Carolina or picking on you guys. Across the country, we're having the question, we need to increase access to behavioral health. Primary care is one of the primary opportunities to do this. We don't have the luxury of scheduling 7 one-hour patients a day for therapists to work in a primary care setting because there's so much need. I mean, half of those, if you guys are like my clinic, they don't show up anyway. And it's like, what do we just do with all that time? So what are you guys thinking as you hear about there could be a significant move towards we're going to start scheduling 30-minute appointments, get ourselves a break in there to document and stuff, and that what we're doing can be helpful, because sometimes this is a surprise. I was trained in the 50-minute psychodynamic psychotherapy mode. For me to get into primary care and instead of spending an hour on a psychiatric intake, all of a sudden I'm spending 30 minutes. That was a big adjustment for me. But you're going to start hearing, and Regala wanted to talk about this with, I think she had jump off. But you're going to start hearing, or you may be the supervisor of a department thinking about this idea. Maybe you've got a long waiting list for your therapy patients. You want to increase access. You're a little confused about what's new and happening, and really what you heard last week is some of what's new and happening, that, and then getting people into groups as quickly as you can. That's another thing. It's not new, but getting them in is important. What do folks think about, do you think we can do these 30-minute appointments, or do you have reservations about them? As you heard about, evidence-based interventions last week. What do people think about that? I think a lot of you are therapists. What do you think about the idea of doing briefer interventions? Or what concerns you or you like about it? Or you can put it in the chat box if your speaker's not working, or you just want to put it in the chat box. Because I know people have strong feelings, or I have worked with sites that have strong feelings, but maybe in North Carolina, you guys have already been doing this. And in Colorado, where I came from before I got back home to North Carolina, the expectation was that 50% of your caseload would be brief interventions and 50% would be the traditional 45, 50-minute hour. So we moved to it gradually. We didn't make everybody 30 minutes, but the expectation was half your caseload. What do people think?
I'll start by saying that I don't work as a therapist. I'm not a licensed therapist. I do behavioral health triage, and I'm a bachelor's level clinician. But I have been doing, intakes and crisis interventions and warm handoffs, all that, like the core integrated services for a long time. And yeah, I would say, like, I like the idea of brief interventions, especially if it's like structured and targeted, where there's a format for it. And if the patient knows what they're doing coming into it, right? They can be really clear about, like, this is what we're working on today, and this is what we're here for. It sounds like a great idea. And like I said, I know that's kind of different from what I'm doing. I'm not providing therapy for patients, but I would say generally in my experiences with people, it feels like it usually takes 45 minutes just for a patient to really feel heard, And I know, like, maybe them feeling heard isn't the goal of these therapies, right? Like, these are treatments, these are not check-ins, these are not intakes. But yeah, I would just wonder, it seems like that element of human connection is really essential to this work. And I guess that might be a concern that I would have, that, like, would there still be room within a shortened session to really get that check-in moment with the patient, where you're reaffirming whatever rapport you have with them, you're getting updates from last time, and just really connecting with them.
Yeah, I think that, that's a fabulous point, Kurt, and one we hear a lot. I think this is a different kind of approach, and you have to set the patient up for it. With you and I am going to teach you, we're going to work on this together, language. I'm going to teach you, we're going to work on skills that can specifically help you deal with life outside of this clinic. We're really not going to, I promise, delve into your past, get into some of that stuff that may be hurtful and traumatizing for you. We're really, this is skills based. We are going to work on skills. We're going to probably meet 6 to 8 times. And we're going to work specifically on skills to address your depression. We're going to work on behavioral activation. We're going to work on work with you to reduce your alcohol consumption, So you were real clear with them after, and it's okay if your intake's a little bit longer, that's okay. But you set the expectation, 3 to 6 visits, specifically about skills. And if you need something else after that, after you've learned some skills, if you need some more intensive counseling after that, I'll make sure you get there. And Kurt, there's a so many studies now that have been published. One just came out today that I just saved. That said that, they had bachelor's level people doing problem solving therapy and dramatic reductions in PHQ-9s. So there's a huge initiative in Washington State to train what they're calling BHHS, behavioral health something specialist. I forgot what the other H is for. They are going to train across the state bachelor's level people. When I worked for the Indian Health Service, they trained high school graduates to do this work. So you are the future of us solving the behavioral health workforce shortage, and hopefully you can be a leader in helping us sort that out. I've got 2 QPs that are going to be doing some work in collaborative care in an FQHC here in Asheville. You know, we need to think broader, and we need to value that this is evidence-based and that different people can do it. There is nothing to stop you from doing behavioral activation or problem-solving therapy. And I can send you the study that I just pulled this morning, but there's a lot of studies. They're doing it in Texas, Washington. Here in North Carolina, they're allowing a bachelor's level person to be the collaborative care manager in collaborative care. You don't have to use up one of your therapists to do that. So I think those are very good points, but you do have to set the expectation. We're going to do about 3 to 6 visits. I'm going to teach you some specific skills. We're going to track how you're doing. Remember that PHQ-9, GAD-7, PHQ-9? You show the patient they're getting better. And if they're not, then refer them. So maybe what you're doing with brief interventions is it's like a cushion. It's a place to learn skills before you jump over into EMDR or something that's, they always say about community mental health. I go in, I get an 1.5 hour intake. They rip off all the bandages and send me out bleeding and bloody because they don't have any time left to teach me anything, to do any kind of therapeutic intervention. And then they send me off to a therapist, because that was just my intake, who does the same thing. So this has kind of taught us there's something we're doing that's not helping in some of our traditional work. And we are too needed in primary care to simply recreate the therapies that we were taught. And there's a note in here from Raney about the adjustment coming from community mental health. Oh my gosh, that is quite the adjustment to go from 15 to 30-minute sessions after you were not only doing 1 hour, you were trained to do 1 hour. And we were trained, if you don't do 1 hour, then you haven't really connected with the person and been heard, right, Kurt? That's what you're saying. We try to be very specific, and you want to be very specific right up front. 3 to 6 sessions or 6 to 8. One of you said 6 to 8. I don't know if that was Kurt or Nathan. And just be specific. And as Raney said, motivational interviewing, mindfulness, CBT, and helping patients shift their focus. Now, one of the cool things that have happened with COVID is also doing these briefer interventions by telephone and by telehealth. It's somewhat helpful when the patient drives all the way to your clinic and they have a 30-minute session. They spend more time driving out there and carrying on than they did in that 30-minute session with you. And sometimes you'll hear them fuss about that. I came all the way down here and we met for 20 minutes and said goodbye. If you think about it, that's what happens with the primary care provider. So we also have to put on our primary care hat and say, this is what happens across primary care with their PCP. This is what happens, 15 to 20 minutes and they're out. So just think about, how do we adapt to see more patients, to do it effectively, and to set the expectation that this is what we're doing. Your primary care provider asked me to see you. He wants me to teach, she wants me to teach you some skills to help you deal with day-to-day life. We will meet 6 to 8 times. And after talking with you, I think I have a couple things in mind. I think behavioral activation and maybe some written exposure therapy might be helpful for you. Okay, so you're setting that expectation. People will still get what I call sticky And when you're trying to discharge them, they don't want to go. You guys, I'm sure, have had plenty of those. But that's why I use your measurement tools. PHQ-9, GAD-7, PCO-5, things are falling. They're looking better. Show them the scores, or they'll start up scoring because they don't want to leave, but show them the scores, how they're getting better, encourage them, and then let them go, discharge them. There's too much stuff that goes on where we just keep people forever, and then we do once a month check-ins. Instead of discharging them from mental health, we do once a month check-ins because we think they need once a month check-ins. And they don't really need that. You need that spot to get someone else in who's out there suffering. So that's what's going through the heads of some of your administrators right now, is how do we do this? How do we do it evidence-based? And how do we relieve suffering by getting more folks in and at least getting them something? And I would say, Kirk, every intervention is therapeutic. I don't care what you do. I tell my psychiatrist that, who say, oh, I got so many patients I'm seeing. I'm like, every intervention is therapeutic. You listened, you sat there, you taught them something. Great. Raina says, is there ever a reason you go beyond 6 to 8 or refer out? I don't think you have the luxury of going beyond 6 to 8, but one of the things they say in written exposure therapy, if it doesn't work, refer them out, or start over 5 more sessions and pick a different trauma and see if that works. So 6 to 8 is kind of the prime. Now, one of the things you can also do if you want, if any of you are trying to implement the collaborative care model of integrated care, that's more like 3 to 6 months of care. And so you can extend out with something, again, we're using different models, right, to get at the same thing. So that lets them go out 3 to 6 months. They're still getting brief interventions, but it lets us go out a little bit more. Other folks, you know, most of you have set this 6 to 8. I hear it all the time from other folks. Do you guys have a limit on how many times you can see the patient? You've been told by your boss, hey, let's try to get this done in 6 to 8 or 3. I've heard 3, especially for people that are super integrated. You're up and down the halls and passing off patients right and left. I've heard maybe 3 at the most. What are folks, is anybody held to anything? Ted, you got to give up at some point, Tiffany? Or you can just go as long as you need to?
I'm also not a therapist. I'm CADC,
But
so
you look like one, Ted.
that's what people tell me. Yeah, I'm a CADC, so people I'm seeing it's for a long time, regularly.
Mhm. Yeah, more of a case management role for people with more serious mental illness, that kind of thing. Okay. What about you, Tiffany? Have you been told, hey, girl, get them out of here, 6 to 8 sessions?
No, I'll be honest, this is something that we do struggle with in our agency. Being very rural, there's not a lot of places to refer people out to who do need that longer support. And
Mhm.
so we do wind up hanging on to people and being their psychotherapist for longer than what should be in true integrated care. And so that's something I personally have been giving a lot of thought to, and trying to develop my elevator speech to give to patients to really explain, like, this isn't that, and set the patient up for a different expectation before agreeing to services with me.
Yep, and setting it up front. I almost feel like you got to give them a piece of paper and remind them they signed it. But
Yeah.
we have to ask ourselves too, are we doing a PHQ-9 or GAD-7 or PCL-5 or an audit C every month? And they actually are getting better, and all we're really doing is checking in. Some people just need a friend. You're the only person they have a deep conversation with once a week or once a month or whatever it is. So we have to be fair about medical necessity, measuring symptoms. It's easier to keep a stable patient than to pick up a new one who's in crisis. I know all that. I've been there. I'd love to keep the easy ones. But at some point in the country, in the nation, in North Carolina, people are suffering because we're doing that. They're suffering because we're not doing some briefer skills. They need skills. They don't necessarily need checking in all the time. They need skills to walk out of your office that day and deal with life. So it's just a mindset change. You're gonna probably be hearing about it from your supervisors. I know it's across the country, everyone's scratching their head. Did we just create a private practice model in primary care rather than actually creating something that's what we should be doing in primary care? And there's a lot of head scratching and wondering, and you're going to hear about it. It's not a reason to flee primary care. Oh my God, if I can't do this, I'm going to go out and open a private practice. It's a reason to sit and try and work with your team to say, maybe I do half and half. Teach me how to do it before you dump me into it. I mean, I would hope people don't flee, but that they say, all right, I'm gonna give this a chance. It doesn't work. I can rethink my options, but I'm going to give it a chance. And I think that's what's important, Tiffany, and telling the patient when they walk in, what's going on. Now, the hard part is all the people you already have on your caseload. Those are the hard ones to tell. Hey, you've been doing great. We need to look at discharge.
Yeah.
Over the next 6 months, it's like, no. Over the next couple months, you're doing well. It's been, you know, when you retire or something, don't pass them on to the next person either. We see that too. I have to get my psychiatrist. Their meds are stable, man. Send them back to primary care for refills. Stop refilling their meds. You're taking up a space for someone who really needs you. That primary care can't get into you. So don't take up that space. Send them back to the PCP to refill their Lexapro. You don't need to keep doing that. So it happens in a lot of places. It's not just with you guys, but in particular, a lot of thoughts going now towards the work that you guys are doing your best to do. So, okay, we have 2 minutes left. I want to remind people we're going to talk, I think, about, remind me, Stephanie, special populations next week. We're not going to do substance use. It's too big of a topic. We're going to do perinatal, pediatric, and geriatric, and just thinking a little bit about how might you approach things differently. Many of you work with those populations. I'll be quite interested in your experience. And then I can add to my slides when you tell me cool stuff. So that's the plan for next week at noon, same time, same place. Let us know if there's anything else you need, but those are the 3 we're going to do, because that's substance use is something special topic, lots of information needed, and something you probably know more about than some of these other special populations. So I will see you next week. Stephanie, any last comments, or are we good to go for next week?
I think we're good to go, but if anyone has questions they want to solicit to Dr. Raney before next week's session, feel free to email us at info@southeastmhttc.org, and we will send those over to Dr. Raney so she can possibly address them in that session. And that's it.
All right, guys, enjoy the rest of your week. Bye-bye.